As you all know, low back pain or lumbago is a very common condition we come across in our clinical practice. To teach us approach our lumbago patients in a better manner, we have with us Dr. P S Mamtora, who is a consulting orthopedic surgeon practicing in Juhu, Vileparle, Andheri since about 3.5 decades. He did his UG and PG from TNMC and Nair Hospital, Mumbai. He has been interested in teaching basic clinical orthopedics since the same time. Areas of interest are conservative management of musculoskeletal disorders. Please welcome Dr. Mamtora.
Good morning, everyone. Thank you, GPA and Dr. Preeti Bhargav and the team for inviting me to talk on this. Backache is a very, very common complaint which all of us will face, either ourselves or through our patients. And we were talking about AI taking over, and those who will not do AI will, physicians will be taken over by AI. The answer is no, because history taking will still remain the core of everything that we do. It is more so in the backache. These days you will have patients who are already having a backache for only 15 days, but they would have done an X-ray, an MRI and a BMD and then come to you. The problem is that they want to treat the report, and unfortunately we get sometimes swayed by that, and we end up going the wrong way. So history taking forms the core of everything in clinical medicine, and more so in cases of backache, because your MRI may show 3 discs, and on history taking you realize that that disc is of no value. In him, this pain was probably related to low vitamin D, or was probably related to a bad posture. So please take a good history when you are dealing with a backache. Obviously, backache can be due to multiple causes, and I am not here to deal with the lower 5. I am here to deal with possible orthopedic backaches. And when I say back pain, I am talking about even the cervical pain. I am talking of the entire spine. So when a patient walks to you in the OPD, you can broadly put them into a few of these categories so that it becomes easy from where to go to where to lead you to. Most of them in the history itself will be able to give you whether they fall into the mechanical backache variety, the inflammatory, the infective, the miscellaneous, which I would include as the mineral bone disease, osteoporosis, metastasis, and the non-specific, which is very, very, very common. When I say non-specific, I mean those which don't fall into these categories, but bad postures, mental stress, which are extremely common and are causes for pain, and may be a concomitant cause within a mechanical one which is going on. When you pick up a mechanical back pain, understand this: it can happen in any age group. It can be an acute one, it can be acute on chronic, it can be chronic, it can be subacute. And when I say mechanical backache, I am talking about pains which arise out of a faulty mechanics within the spine, which could be a disc prolapse, a discogenic pain, a facetogenic pain, a degenerative spine, a listhesis, a lumbosacral strain. Any of these mechanical changes are known to cause mechanical backaches, and they will behave in a category of their own. These pains will be worse on bad activity, will be worse on certain postures, will be better by rest. You need to keep this in mind, because this is what will be against something else which fall into another category. These backaches or neck pains can have a radiation of the pain along a dermatome, meaning the pain can arise from the neck and go along the dermatome of C6 going up to the thumb. Or they can have pain coming from the lower back going down the lower limb posteriorly into the posterolateral aspect of the leg, which could be a S1 dermatome. So the pain radiating along a dermatome is more of mechanical. Thank you. you will have a situation where the pain may be associated with a neurological symptom. You have a compressive radiculopathy. The patient may complain of tingling, numbness, or loss of grip, or while walking, the chappal falls off. So there will be a motor or a sensory component to the symptom, which is not always present, but when you have a motor or a sensory symptom, usually you are looking at a mechanical backache. A lot of backaches which have a compressive radiculopathy, which have a canal stenotic component, can give us claudication. So we are talking of a neurogenic claudication, which will be part of a mechanical backache. When you look into the other category, it is the inflammatory backache. These are reverse. These are pains which will be lasting for at least 6 weeks for you to categorize them into an inflammatory back pain. If they are lasting only for 15 days, even if they were to start off as an inflammatory, you cannot label them inflammatory till they have lasted at least 6 weeks. These pains are always better by activity and worse by rest, which is against the mechanical. Mechanicals are better by rest, whereas inflammatories are worse by rest. So morning when they get up, they are extremely painful and stiff. And that morning stiffness will last you at least half an hour and more. And that could be one of those follow-up criteria. Their radiation will not be along a dermatome. That is a very diffuse radiation along a chest wall or along the gluteus. That kind of radiation will be there. And they will never have radicular pain, meaning you will not have the pain radiating along a dermatome. There will be no neural symptoms in that sense. But they will have extra-articular manifestation symptoms, which could be at different systems involved, and we'll go to that later as we come further. Most important is the stiffness in the spine is going to be long-lasting. They will talk that, since last 5 years, I think my ability to bend has gone down further and further. So there'll be a progressive stiffness when untreated. When you look at infective back pain, because we have endemic COX, any back pain which does not fall into the routine, any back pain with the routine treatment does not get better, keep a high index of suspicion for COX, and gone are the days when you will find a constitutional symptom of fever, loss of weight, loss of appetite. I have had patients who are 100 kgs, never lost weight, never had any constitutional things, and they were multifocal COX in the spine. So, but of course, COX spine these days is muddled with atypical mycobacterium and mycobacteria which are resistant to drugs. But high index of suspicion is the thing. Children with spine pathologies which have significant restriction in range, think of COX. Mechanical back pains are those which I talked of, that they could be the discogenic pain, the classic disc prolapse, the lumbosacral strains, so to say, the spondylotic changes where it's a lumbar spine osteoarthritis or a cervical spine osteoarthritis. A lot of times you can have a pure facetal osteoarthritis giving you symptoms. And of course, the canal stenosis as the thing progresses further. Usually, unlike inflammatory backache, the mechanical back pains are localized. If you have a cervical pathology, they'll have more of neck pain. If you have a lumbar pathology, they will have more of low back pain. And yes, you can have both degeneration going on, cervical and lumbar, but they will not be diffused like the inflammatory. Mechanicals are more localized. And in mechanical things, the history will suggest you that they have induced the acute attack following a particular wrong posture, like they drove for a period of 5 hours, or they got up in the morning and when they just bent to pick up something, they got a catch. Or you have a situation where they were fitting their luggages and then they lifted a large bag, and following that they got severe back pain. So you're going to get a particular event which may induce an acute attack, which usually is present. These days, this is unconnected, but directly unconnected, but indirectly there is a connection. A lot of viral fevers, I have seen this happen. They develop after a period of viral fevers, those who are prone to develop discogenic pains, their muscles go for a toss, they go into a wrong posture even a little bit, and they induce a discogenic pain. So they were the prone varieties, they were those who were having discogenic pain episodes, and they induced that following a viral fever. The fever went away, the muscle aches were still there, and they went into a wrong posture, induced a discogenic component. The radicular pain can be excruciating. People can call you up in the night, pain going down their arm, pain going down their leg, saying that, morning it was not so bad, but now I'm in severe pain, please do something. You got to differentiate the neurogenic claudication from the vascular claudication, because majority of the lower back issues where there is a stenotic component will come up with some level of claudication. The claudication in the neurogenic variety is usually things where they do not get better by just stopping. Most of the patients, when you differentiate it between vascular and neurogenic, the neurogenic guys will have more of proximal pain, and their pain will settle down only when they either stoop or they sit. There are times that the claudication is so severe that they have to sit on even the footpath to relieve themselves. Whereas if it's a vascular claudication, just a stoppage of walking is good enough to relieve the claudication. That is a very major important thing. The simple pathological, pathoanatomical fact is this, that in a stenosis, the canal size is this. Once you stoop or sit, there is a flexion happening, so the canal will improve in size, thereby relieving the epidural engorgement of the veins, which will relieve the stenosis functionally. Anything in the mechanical axis which goes wrong usually will create backaches, which could be posture also. All discogenic or degenerative joint disorders of the spine have three basic stages each individual human being on the face of this earth will undergo. Get this very clear. Once you understand this, the treatment becomes very, very easy. Degenerative backaches are for every person on this earth. We go through three stages of degeneration: the stage of dysfunction, the stage of instability, and the stage of stabilization. Every single person on the face of this earth will go through this. So the stage of dysfunction, the stage of dysfunction is where you will develop backaches. And it goes through right from 15 years of age to 45 years of age. They will develop discogenic pains. There are these so-called things that itna chota hai or kaise disc ho gaya. So right from 15 years of age, it can go. There's a stage of, because there is continuous dysfunction, it goes through stage of instability, which is between the age group of 35 to 70 years, where the degeneration of the disc and the facet joints become further, the ligaments become lax, and you start developing unstable zones. And then comes, because there's too much of instability, the nature tries to throw osteophytes, makes the ligaments more thicker, and hence causes them to become stiff. That is the stage of stabilization. So that reduces the instability pain, but in return, it gives us stenosis. Why do we get pain? Though the discs are aneural, but understand this, the disc pain is arising out of this sinovertebral nerve. The posterior longitudinal ligament and the annulus here is provided sensation by this sinovertebral nerve. So any little annular tear or swelling or an annular tear causing a local chemical reaction triggers this nerve to give pain, and because it is part of this, they will cause muscle spasm, paraspinals, and that's how the whole thing goes. Remember this, In the lumbar spine and in the cervical spine, the nerve roots are placed differently. So when you have a C4-5 disc, it's the C5 root here. Whereas when you have a L4-5 disc, the L4 root goes here and the L5 root comes here. So when you have a disc of L4-5 variety, the L5 root here will get affected. Whereas if it is a far lateral, it will be the L4 root which will get affected. Clinically itself will be able to diagnose these disorders because we need this basic anatomy imprinted in our brain. Different dermatomes I have just made you to remind that through a dermatomal hypoesthesia or a myotomal reduction in power, we can and are able to easily diagnose the exact amount of disc prolapse. I mean the exact localization of disc prolapse. These are basic anatomy and physiology features which we have forgotten. These are the kind of protrusions which will cause the nerve root irritation. The visual makes a big difference. This is what I was trying to tell you. If the disc is here, it will compromise this. If the disc is far lateral, it will compromise that root. Why am I talking all this? Because we come with patients already having MRIs in their hands, and they want the diagnosis. No, they want the treatment. Different levels of affection of discs. These are disc desiccations, a little bit of bulge, protrusion, extrusion with sequestration. Different degrees of pathologies. Sometimes just pain here is not equal to a discogenic pain. Cervical pain with a radicular pain is, and the unequal spasm is one of the things of mechanical pains. You will develop unequal spasm. One of the trapezia is more than the other. The lower back, generalized pain and tenderness is of no value. It has to be radicular in origin for it to be of a discogenic or a spondylotic radiculopathy variety. The site of pain. People talk of, he's got SLR 45 degrees, so he has disc. Never. The degree is not diagnostic. It is the pain which is diagnostic. You can have a 45 degree SLR on both sides, which are painless due to only tight hamstrings, which is not a disc. And you can have a disc where one side is 90, the other side is 80, and that 80 is giving him or her a lumbar pain. That is a discogenic pain. These are small reminders that clinical medicine still is huge. That is what gives you the right diagnosis, even though you may have an MRI. There would be 3 discs involved. I'm again saying the same thing on the MRI. You need to pick up whether that is the L4-5 disc, which is the right now causing pain, or it is no disc at all and it is something else which is causing the pain. When you have a C5-6 disc protrusion, the pain will go along the lateral aspect of the forearm up to the index finger or the thumb. You will have loss of biceps power. If you have a C6-7 disc prolapse, you will have the middle finger, that is a C7 hypoesthesia, and there will be weakness of the triceps. C8-T1 roots are rare. I mean, C8-T1, C7 T1 discs are rare. These are still rarer. The L4-3-4 disc will give you a pain radiating along the thigh, where there is a sensory loss on the L3, and you will have a quadriceps weakness. The L4-5 disc, which is the most common, will compress the L5 root, which is why the extensor hallucis longus weakness is one of the most common weaknesses you will find in a discogenic pain. What I'm trying to show with these kind of pictures is a simple fact. Again, clinical diagnosis in backache is absolutely primary. Plain X-rays are of zero value in diagnosing or confirming a disc disorder. Absolutely zero value. You can have a disc desiccation shown on the X-ray, but that does not mean that this patient has a disc disorder. As I showed first, there are 3 stages of degeneration. So we all are in different stages of degeneration. Our L4-5 and L5-S1 may be in stage 2, whereas L1 and L2 disc may be in stage 1 still. So each person will have different stages of degeneration in different segments of their spine, thereby giving a different imaging picture. But the imaging picture can be corroborated only when you have this clinical diagnosis. If you want to confirm a disc, apart from the clinical thing, which is the primary thing, the next would be an MRI, where it is not just a protrusion. Here you can see that there is an annular tear with an extrusion. That is fitting with an acute onset of a low back pain with a radicular pain. And there is a restricted range of motion. The range of motion is asymmetric. And there is an associated SLR if need be. And there is a neurodeficit or a no neurodeficit. And then this MRI picture comes up. Then this is the diagnosis, that this is the axial cut showing the annular tear with protrusion. And the previous one was showing the sagittal cut showing the protrusion. You can have large extrusions causing huge amount of compromise. You see this whole lateral recess. Here the lateral recess is not so bad. Here the lateral recess is significantly compromised, and there is an inferior migration because the next cut, which is a bony cut, still shows the disc. So these kind of huge disc protrusions, extrusions, will usually be associated with a neural compromise. See this, huge. Now see, these discs are still well hydrated. It is only this disc which is dark, which means it is dehydrated, and there is so much of protrusion with some amount of migration. The complete bed rest is the treatment of choice, which can vary from 2 days to 6 weeks. As we go going more and more, our bed rest periods are reducing more and more. And when we say complete bed rest, not going to work does not mean bed rest. This is the standard thing with patients. And these days with work from home, they say, oh yeah, I have not been going to work since last 15 days. But they are sitting on the bed with their laptop, which is making the disc worse, because this is the basics. When we are standing, the local disc pressure is a single unit, imagine 100. When we lie down supine, it becomes 25. And when we lie down on the side, it becomes 75. But the moment we sit, it can go up to 135 and 150. And when we lift weights, it can go high. So sitting at home is actually detrimental. It's very, very important that we understand that lying down is the least pressure on the disc, and that's why bed rest is what allows that annular tear, what allows that edema around the sinovertebral nerve to reduce the fastest. Sitting always increases the pressure more than standing, and that's why sitting after an acute disc is to be avoided. And as we allow them to sit with time, as they get improved, don't allow them to sit for more than half an hour. Modalities available are non-steroidal anti-inflammatories, oral steroids, injectable steroids, epidural steroids, muscle relaxants. Physiotherapy. Physiotherapy does not only mean the modalities of electrical variety, it also means the mechanics. The McKenzie protocol is a mechanical way of reducing those annular tears and those protrusions. This is a mechanical way of reducing that swelling, which reduces the spasm, improves the range of motion, and definitely improves the speed of improvement and getting back to daily activities. Many other things may be needed in some patients. You may end up with a discectomy surgery. Nucleolysis is no more, it's never available in India, but in the West, it is now going down. Long-term treatment is going to be very important for people who develop disc, because a person who has had a disc prolapse once in his or her lifetime will always be a higher chance of developing one more discogenic episode. So posture awareness is extremely important, and specificity of exercises to improve the quality of core strength, to improve the proprioception is important. Just reduction in pain is not equal and over. It is important that they go through a long-term exercise program to prevent long-term problems. This one major statement. All disc disorders will get relief of pain, but they are never curative, because the disc, once degenerated, will always remain degenerated. They can never get back to their original level pathologically, physiologically. So even a surgery that you're doing is palliative in one format. So all disc disorders are treatable, but true definition of the word cure, the answer is palliation, not cure. The other good thing is, whatever you do at the end of 5 years, all discs will behave the same. So it is through those 5 years that they will suffer more or suffer less or suffer more frequently. By the end of 5 years, most of the discs will behave very similarly, whichever pathy they go through, whichever treatment they go through. And this is a study across all geography, across all big studies, that every human being on the face of this earth at the age of 50 years will have degenerative changes in his or her spine. So, no big deal. The point is, the treatment for the symptom is important in the specificity. Posture awareness I was talking about. Sitting from buttocks to mid-back, full support. Keep the hip knee bent, supported on the chair or on the table, and the chin has to be not protruded. See, most of the times these days, because of our screen use, most of us or most of the patients tend to throw their neck, and that increases the load. The same thing happens to the back. Because they are involved in their work, they tend to slouch. So improvement and correction of the normal lumbar lordosis and getting back the cervical lordosis normal during posture awareness is extremely important. Small things. Patients sitting without support, as I was saying, looking down and working. Rather than that, sit with support, get it up, that will help. Bending and taking shower instead of that hand shower. Sleeping with one pillow, sleeping with pillow on the sofa, wrong. Small things in postures are going to be so important. This is what happens in the long run, and people see too much of extension. People who have a bad tummy with hyperlordosis tend to reduce their canal size at the facet joint level. So the whole load is now on the paraspinals, which is why they remain tight and they are going to give you pain. These are very small things, very boring things for the patient and for the physician also. This is wrong, this is right. This side is wrong, this side is right. Small things, but make a big difference in the long run. Helps us in preventing recurrence. Getting out of bed. People tend to just jump out of bed. Turning on one side, taking weight on the load on both the right elbow, left palm, and then getting out. This is always a better posture awareness. Because it's like a tent. You have good muscles, the spine remains stable. You have bad muscles, the tent collapses. Inflammatory backaches are the pains which are seronegative spondyloarthropathies. Here, the pain has to be for at least 6 weeks. It will involve most of the entire spine. The pain is worse at rest and better by activity. Usually, there will be no neural symptoms. And remember this, morning stiffness has to be of at least half an hour for it to be of value. a morning stiffness of less than half an hour usually will not be inflammatory. And there will be joint involvement in inflammatory spondyloarthropathies. You can have one hip, one SI joint, one shoulder, one knee. Usually they are oligoarticular, unlike rheumatoid, which are polyarticular. And most of these will have some level of extraarticular manifestations, even though it may be as simple as an enthesopathy, like a heel pain lasting 2 years is an enthesopathy, which could be a concomitant to an inflammatory backache. It could be aphtha ulcers, it could be frequent diarrhea, dysentery, it could be frequent UTI. All of these are extraarticular manifestations of SSA. And SPA or SSA, as they call, are multiple varieties, and you can have different formats of presentations. The enthesopathies, as I said, are very, very frequently missed extraarticular manifestation of SSA. The heel pain, a little aponeurotic pain, an enthesopathy around the knee, an enthesopathy at the attachment of the tendo Achilles. These are chronic, long-lasting things. Try to look for a backache which has been lasting long, and they may be connected, and you may have missed a small SSA. Ankylosing spondylitis, the classic SSA. The way to diagnose it is, again, clinical. If you have backache lasting 3 months, which is unrelieved by rest, very important thing. There will be pain and stiffness in the thoracic cage. There will be limited chest expansion, less than an inch, the difference. There will be reduced lumbar flexion in the form of a Schober's test, and an X-ray finding of sacroiliitis or an X-ray finding of syndesmophyte. If you have one clinical and one sacroiliitis, you're done. You have ankylosing as the diagnosis. Schober's test, classic way is to pick up 1 point between the two PSIs, 10 centimeters about. When you flex, it will become 15 centimeters if it is a mobile spine. So if it is less than 15, which means the difference is less than 5 centimeters, you have a positive Schober's test. And majority of the ankylosing lasting long will have this, what is known as a round back deformity. Their cervical spine lordosis is lost, their thoracic kyphosis is increased, their lumbar lordosis is lost. So you have a gentle round back all along, which is what we term as then subsequently as a bamboo spine. Because the costovertebral joints are affected in the dorsal spine, the chest expansion will be limited. So just looking for a good chest expansion is a small test. It can put you on the course of one more corroborative evidence as ankylosing. SSA is more common, of course, than RA. And HLA-B27 is not diagnostic. Please, HLA-B27 is positive in 5% of normal population. HLA-B27 doesn't become positive or negative. You're born with it. It's a tissue type. It only corroborates your clinical diagnosis of an inflammatory backache. So please make sure that your SSA, your SPA was diagnosed clinically. The indications. This is the level of percentage that is distributed for HLA. See the fused spine, right? Your X-rays will show this bamboo spine, the syndesmophytes fused. Classic bamboo spine. The sacroiliac joints are totally fused. Sometimes the spine may be fine, the sacroiliitis may be the only thing. This is the sclerosis, the erosions. Sometimes even the X-ray may be normal, but clinically you are pretty sure that it is a sacroiliitis and an SSA with a history. An MRI may pick up early edema alone and hardly an erosion. The round back. Sometimes you can have only facet joint fusion as one of the signs. You may not get a classic bamboo spine, just the fusion of the facet joints. In non-ankylosing, that writers and all, you can have a large asymmetric one-sided syndesmophyte. In some of the other SSAs, you can have only a corner erosion. Infective backaches, most of the times is Cox, but these days we are looking at atypical mycobacterium. Of course, pyogenic, but pyogenic is extremely rare, but once you see a pyogenic discitis, you will never forget it. The pain is excruciating. Even a small touch of the bed of the patient where he is lying down can make the patient shriek in pain. So if you've seen one infective discitis, you'll never forget it. It's excruciating pain, severe restriction in range. Patient is always in bed, even turning in bed becomes difficult. And infective discitis usually has some history of an intervention before, whether it's a surgery or a lumbar puncture. Pure pyogenic discitis, hematogenous, extremely rare. Infective backaches have to be with high index of suspicion. Range of motion restriction in children is usually, children will not have malingering. So if you have a significant restriction in spine range in a child, think of Cox. Or when an adult backache is not responding and not behaving well, think of Cox.
Sir, last 5 minutes.
Yes, ma'am. Cold abscess can be tracked anywhere. Different varieties, different places depending on where your pathology is. MRI is a very classic one here with the epidural abscess, but Cox pickup is best in an MRI. It is extremely sensitive, though not specific. And with today's day and time, your diagnosis of Cox has to be having a tissue diagnosis. There has to be a biopsy done for histopath, for gene expert, for growth and culture, and for antibiotic sensitivity. Cold abscesses, drainage, surgically. The miscellaneous causes, most of them being osteoporosis, very common is being the osteoporosis. It's a skeletal disorder, as all of us know. And osteoporosis, being a silent disorder, will have things which are missed easily. This is the classical thing where the Aji has gone for a pilgrimage within the Bombay city during a Shravan Mass, gone through a bus arranged by the local group. She had a nice time, but she was at the back seat of the bus. After 2 days, her backache worsened, and then when you asked her details, she says that, I had a bumpy ride. So those bumps created a wedge compression of the spine, and your clinical examination becomes very important. You will find a very gentle gibbus or a slightly increased kyphus at the DL spine, and that tenderness will be pretty deep. You need to make sure that you take an X-ray of the dorsal lumbar spine. Do not take the standard lumbar spine X-ray. Take the X-ray from D8 to S1. Please make this a routine. In old patients, do not ask for X-ray LS spine. Ask for D8 to S1. Vitamin D deficiency is another very common cause of backaches. Postural pains are very common because of the use of screens. There are a lot of people who will have a lot of postural and psychological causes for pains. Even if they are lasting long, you will find that their range of motion will be full, almost full. There will be no neurodeficits, there will be no neural signs. So despite a long history, having a good examination finding should make you look for that. Metastatic pains can be due to primaries from multiple myeloma being very, very common. Prostate, breast, renal, thyroid, and adenocarcinomas. Protein electrophoresis is what I routinely ask for people who are old with backaches, and definitely old people with osteoporotic wedge compression fractures. Thank you.
Thank you, sir. I request Dr. Suman Pandya, Convener Community Committee, to felicitate Dr. Mamtora.
Congratulations to Dr. Mamtora for taking such a nice lecture.